Levalbuterol is available through common trade name of Xopenex. It is a bronchodilator and a sympathomimetic. The way it works, it's a beta 2 agonist, which results in bronchial smooth muscle relaxation, and it can have a slight peripheral vasculature dilation effect, although it's very minimal. Pregnancy class for it is C. So what do we use it for? Bronchospasms with COPD, asthma, all the good stuff, pretty much anytime they're having trouble breathing. We can also use it for hyperkalemia, just like we can use albuterol for hyperkalemia, we can use levalbuterol, and it increases the uptake of potassium back into the cells, similar to the way insulin works whenever you're given that for hyperkalemia. So the main reason we're using levalbuterol over regular albuterol is going to be because it has less side effects, less adverse reactions, all that stuff. It doesn't usually cause the tachycardia that is related with using regular albuterol. Levalbuterol is a more refined version, just follows the R isomer, and whereas regular albuterol has both R and S isomers in them, part of the albuterol system. Levalbuterol is just more refined, so it typically has less side effects. Contraindications to look for: tachydysrhythmias and prolonged QT interval. We still want to avoid it with those. Some adverse reactions that it can cause: headache, lightheadedness, throat irritation, restlessness, hypertension, tachycardia, chest pain, nausea, vomiting, dyspepsia or upset stomach, hypokalemia, and also hyperglycemia. Again, it's going to be usually pretty mild though, and a lot less side effects than regular albuterol. Some interactions to look for: sotalol. If you're giving this and the patient is also taking sotalol, it can cause a bronchospasm. Phenothiazines that may increase the QT interval and to an unsafe point, really. And then if a patient's taking TCAs, MAOIs, or other sympathomimetics, then levalbuterol will increase those effects of those medicines. Typical adult dosing, I'll contraindicate what it says in the book, but this is more accurate. Typical adult dosing is going to be 0.63 milligrams, and that's usually mixed in 3 milliliters of sterile water or normal saline, and then you nebulize that with O2. Pediatric dose, pretty much half that, just 0.31 milligrams. Again, it's mixed with 3 milliliters of sterile water, and then you'll nebulize it, just like you would albuterol or something like that. The book says adult dosing of 1.25 milligrams up to 2.5 milligrams, but most protocols I've looked at are they use the adult dosing of 0.63 milligrams. So it does take a little bit to start working. It takes 5 to 15 minutes usually for the onset. Peak effects within 60 to 90 minutes, so it might not be super quick till you get those peak effects, but it's relatively fast that it starts working, and it does last in the body for 6 to 8 hours, something like that. Other than that, there's nothing else really that you need to know, though. The main reason a lot of systems don't use it on the truck is a cost issue. It is much more expensive than albuterol, and so yes, you don't have the adverse reactions or side effects, but at the end of the day, it's the almighty dollar that sets up a lot of this stuff. So it is cost prohibitive for a lot of systems to carry it on a regular basis.